Advanced Clinical Neurology and Diagnosis. My name is Tom Lewis, and today I will be doing a presentation on Klumpke palsy. Klumpke palsy was first discovered by American-born French medical doctor Auguste Desjardins Klumpke in 1885. Auguste's paper described a disorder in which patients had total paralysis of the lower brachial plexus with sympathetic fiber involvement after experiencing trauma. Unlike Erb's palsy, in which muscles subsequently recovered, in Klumpke palsy, muscles innervated by the lower roots of the brachial plexus experienced continued paralysis. Pathophysiology. Klumpke palsy occurs when the arm and shoulder are hyperabducted and elevated with enough intensity to traction the lower brachial plexus. The brachial plexus is a bundle of singular nerves that exit between the anterior and middle scalene muscles in the anterior lateral section of the neck. Through here. Traction of the arm and brachial plexus causes the C8 and T1 nerve roots of the spine to avulse, stretch, or rupture. Ultimately, this causes sensory and motor paralysis of the structures innervated by these nerves. Typically, patients who present with Klumpke palsy have normal elbow and shoulder strength, but experience a loss of the sensory and motor functions of the hand. This weakness in sensory and motor function correlates to the side of the body that was subject to the trauma or injury. Moreover, damage to the C8 and T1 nerve roots inhibits sensory and motor functions of the intrinsic muscles of the hand, wrist, and finger flexors. Over time, these fingers contract to form a claw, which prevents patients from conducting fine motor tasks. Additionally, patients experience hand numbness in the ring and pinky finger within the distribution of the C8 and T1 dermatomes. And as you can see, the boy in the picture on the left has a characteristic claw hand which is associated with Klumpke palsy. Horner syndrome. Due to the involvement of the T1 sympathetic fibers in Klumpke palsy, Horner syndrome often accompanies motor and sensory deficits in the upper limb. Horner syndrome is a rare condition that is characterized by constriction of the pupil, miosis, drooping of the upper eyelid, ptosis, and an inability to produce sweat on the face, anhidrosis. Types of nerve injuries from trauma. In severe lower brachial plexus injuries, trauma can cause nerve roots to tear away from the spinal cord in a process known as avulsion. These types of injuries are often difficult to repair with surgery and result in permanent paralysis. In instances where the spinal nerves are mildly stretched, it may heal on its own or with non-surgical methods which aim to return normal function. When trauma causes a forceful traction, a partial or full tear or rupture of the nerve can occur. These nerve roots that are ruptured may require surgery to heal. Population groups affected and the prevalence of Klumpke palsy. Traction injuries to the lower brachial plexus occur most often in infants during childbirth and in adults when the shoulder is depressed during falls. At the time of its discovery, Klumpke palsy was common due to the high number of breech births and antiquated obstetric practices. At present, Klumpke palsy is the least common of the plexus palsies, with less than 1 in 1,000 cases reported in the United States annually. Accordingly, infants have the highest incidence of Klumpke palsy, and although rare, it can occur in adults. Due to the location of the brachial plexus, hyperabduction and traction injuries usually subject the shoulder and neck areas to crushing forces, which can damage the axillary artery. Moreover, the trauma associated with Klumpke palsy often results in severe vascular injuries and fractures that can often require emergency corrective surgery. In cases where the skin is not broken, conservative treatment options such as exercising supportive muscles while stretching affected muscles helps to maintain range of motion. Spontaneous recovery from nerve palsy can occur. Most C8 and T1 nerve root palsies require surgical intervention if there is no improvement within 3 to 6 months. Surgery usually involves nerve grafting. However, in cases with injuries proximal to the dorsal root ganglion, nerve transfer or neurotrization is recommended. We will now proceed to the neurological exam of a chiropractic patient in a clinical setting. Hi Chris, my name's Tom. How are you today?
Good, thank you.
That's good. Today we've got you in here because we're going to be examining you for Klumpke palsy. So this will entail conducting a sensory, motor and reflex examination on you of your upper limb, and then we'll also examine you for Horner syndrome, which is an added complication of Klumpke palsy. If there's any pain throughout, please let me know. And are you all happy to proceed with this?
Definitely.
No worries, thank you. Okay, Chris, so now we'll begin your sensory examination, and this is to test your dermatomes of your upper limb. So to do this exam, we will test you for sharp and light touch. This is what sharp feels like. This is what dull feels like. So to begin with, I'll get you to close your eyes, and when I touch an area of your skin, I just want you to let me know whether you feel sharp or light touch. If there's any questions, let me know. So just closing your eyes for me, please. Okay, Chris, now we'll be testing sharp and dull touch, so let me know what you can feel.
Sharp, 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 dull.
Working down the non-symptomatic side.
Sharp, 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 dull. Sharp, dull, sharp, sharp, dull. Sharp, dull, sharp, 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 dull, sharp.
So in that exam, we tested the C2, C3, C4, C5, C6, C7, C8, T1, T2 dermatomes on the non-symptomatic or asymptomatic side. Now we will conduct the rest of the examination on the symptomatic side. Keeping your eyes shut, Chris, just let me know whether you can feel sharp or dull.
Sharp, 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 dull, sharp, dull, sharp, sharp, dull, sharp, sharp, dull, sharp, 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 dull, dull.
So there we tested the dermatomes of the C2, C3, C4, C5, C6, C7, T8, T1. In a patient with Klumpke palsy, Chris would not be able to feel his C8, T1 dermatome. Now, Chris, we will begin your myotome examination. So this is testing the nerve roots that supply the muscles that can create movement. So to begin with, we'll test C1. If you can push your head into my hand and to the side. C2, back. C3, raising the shoulders for me, Chris, shrugging them. C4, bringing the arms up. Resist. C5, back down by the side. Testing C6. So just trying to pull your hands towards you. C6, wrist extension. C7, pushing the arms back towards me. C7. Now we will test C8. Flexing the fingers towards me. And T1, trying to abduct the fingers and resisting. There. Thanks, Chris. In a patient with Klumpke palsy, they would not be able to flex the fingers. C8, they would have extreme weakness, and they would have an inability to abduct the fingers. The median nerve is innervated by the C8 and T1 nerve root and is responsible for providing motor functions to the fingers to be able to produce thumb opposition. So in order to test this on both hands and to examine for Klumpke palsy, now we will test you for opposition, which is getting your thumb to, I'm going to try and pull through each finger. I want you to try and resist each movement. So that's nice and strong, 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 and strong. Now we'll do it on the right side, Chris. So once again, resist, 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 and resist. In somebody with Klumpke palsy, they would have an inability to do this. You would be able to slip through nice and easy due to paralysis or impairment of the C8 and T1 nerve roots. Now, Chris, we will conduct your upper reflex exam. So to begin with, we'll start with the C7 reflex, the triceps reflex. Just relaxing for me there, Chris. Yep, we've got a response there. Relaxing for me, Chris. And we've got a response there. C7 is intact and strong on both sides. This is C5. Initiating a response there. On the right. C6, brachioradialis reflex. Getting good contraction there. Now we'll test the C8 reflex, the finger flexion. And on this side. That concludes the upper limb reflex examination for Klumpke palsy. In a patient with Klumpke palsy, we would see a diminished reflex response in the C8 finger flexion reflex. Thank you. Now we will be examining Chris for Horner syndrome. Horner syndrome is caused by disruption of the sympathetic fibers to the eye and the face, usually of the T1 nerve, and this would be characterized by the normal triad of ptosis of the eye, constriction of the pupil or miosis, and anhidrosis or a lack of sweating on the face. So to examine Chris, or to examine anyone with Horner syndrome, we would be looking on the side of the brachial plexus that has been tractioned. So if it was Chris's right side, we'd be examining him for ptosis of the eyelid, which he doesn't have at the moment. We'd be examining for constriction of his right pupil, and we'd also be examining him for a lack of sweating on the right side of the face. That concludes the examination for Horner syndrome. Differential diagnosis for Klumpke palsy. Klumpke palsy and Erb's palsy share similarities in that they both arise due to the brachial plexus injuries. When excessive force widens the angle between the head and shoulder, the upper nerve roots of the brachial plexus are tractioned in a similar manner to the injuries that cause Klumpke palsy. Additionally, pediatric patients have the highest incidence of Erb's palsy, which can make it difficult to differentiate between the two conditions. Similarly to Klumpke palsy, Erb's palsy presents with characteristic paralysis of the arm. However, Erb's palsy is associated with fixed pronation of the forearm, with an outward-facing palm in what is known as the waiter's tip position, which can be seen in the image on the left. Erb's palsy differs from Klumpke palsy in that it is an injury of the upper brachial plexus, usually affecting the dermatome and myotome of the C5, C6 region. Ulnar nerve entrapment. Distal entrapment of the ulnar nerve at either the medial epicondyle or Guyon's tunnel can produce similar neurological symptoms to Klumpke palsy. Patients with ulnar nerve entrapment present with numbness and tingling over the ring and pinky fingers. As the condition progresses, weakness of the intrinsic muscles of the hand and flexor digitorum fundus causes clawing. As the ulnar nerve has a similar distribution to the C8 dermatome, clawing in the ring and pinky fingers can mimic Klumpke palsy. This provides rationale for listing ulnar nerve entrapment as a differential diagnosis for Klumpke palsy. In an ulnar nerve entrapment, however, the onset of the condition is not as sudden when compared to Klumpke palsy. Thoracic outlet syndrome. In thoracic outlet syndrome, or TOS, the lower brachial plexus is stretched and angulated superiorly, causing neurovascular symptoms. Additionally, the motor and sensory abnormalities of TOS correlate with the muscle and cutaneous distribution of the C8 and T1 nerve roots. Accordingly, TOS can present with symptoms similar to Klumpke palsy. Moreover, TOS can also manifest as the result of trauma, which is the same mechanism of injury for Klumpke palsy. This provides rationale for TOS as a differential diagnosis for Klumpke palsy. Where TOS differs to Klumpke palsy is that it affects more than just the C8 and T1 nerve roots. However, it can still affect the axillary artery. It includes the presentation and neurological examination for Klumpke palsy. My references are on the slide as shown. Thank you.